In this video, we'll discuss about various clinical features of mandibular fractures. So first of all, we'll start from the dento-alveolar fractures. Now, what happens is there is mobility of dento-alveolar segment. Then there is subluxation on avulsion of teeth. Then we will see that there will be horizontal or vertical split of tooth. Then occlusal derangement will also be seen. Then laceration of gingiva. As well as change in alignment of teeth. Now for the management part, reduction of the dento-alveolar segment, then soft foods for 3 weeks, place the jaws in centric occlusion, also stabilizing with dental arch bars or interdental wiring. Now the second one which we are going to discuss is very important. It is the condylar fracture. Now the condylar fracture, it is due to either due to some road traffic accident or due to some personal assault. Alright, now it is classified based on the site or the type of trauma. So type of trauma and type of fracture. Now if it is a direct injury, it will lead to comminuted condylar fracture, or if it is a lateral impact in body region, then it will affect the body on same side, or it will cause the opposite condylar fracture. Now if the impact is on the on the mandible below the chin, so below the chin we can have symphysial or parasymphysial fracture. We can also have bilateral condylar fracture. Then if the impact is above the chin or it is from front, then it is going to be symphysis, parasymphysis and bilateral body. Now there is one more classification, it is the Lindell's classification. Now it basically has 3 main criteria. One is the fracture level, then the relationship of condyle or condylar fragments to mandible, and the relationship of the condylar head to fossa. Now suppose this is it. Now this is the condylar head, this is the condylar neck, and this is the subcondylar region. Alright, condylar head, neck and subcondylar region. Then further you can classify these into displaced, undisplaced, lateral displaced. Okay, I'll draw them. So the first one being the undisplaced. Then something like this. So this is undisplaced, this is deviated, this is displaced medially, this is lateral overlap, this is anterior posterior override, and this is no contact. Then third one was according to the fossa. So alright, then we have some intercapsular fractures. Also, now we will discuss the clinical features. So first of all, very characteristic feature is a characteristic hollow. Then in the condylar fractures, what we also get to see is there is a decrease in mobility. Of condyle, pain, swelling, tenderness, soft tissue, injuries, bleeding of nose, then limited mouth opening, hematoma. Now this further is of unilateral and bilateral type. Now in unilateral, what we will see is that the chin and mandibular midline, they deviate towards affected side. No, it doesn't happen in bilateral. Then in this, what happens is the posterior tooth gagging is towards affected side, whereas in bilateral it is towards both. Now here posterior cross bite and anterior open bite. This is on same side, this is on opposite side. Here posterior open bite is seen. Then this is unable to perform lateral movements, normal protrusion. Now let's discuss the management. For the management part, we will divide them into two. One is the observation and the another one is the closed reduction. Then we will discuss the surgical. In observation, when there is a non-displaced green stick fracture without malocclusion. Also, if there is intercapsular fracture, in children without malocclusion below 10 years of age. Now over here, if there is intracapsular fracture with mild malocclusion. Also, if it is minorly displaced, then also then if there is pain in children less than 10 years. Now in surgical treatment, this is basically Zaid and Kent criteria. Absolute and relative. Now to remember this, I will give you acronyms. So for this, just remember film. So basically foreign body invasion by eye, inability to achieve occlusion during reduction, close reduction method. Also L for laterally displaced fracture. Now in relative, remember bill but with two B's and two L's. Bilateral condylar fracture with mid-face combination. Bilateral condylar fracture in edentulous patients. I for IMF contraindicated cases. I will discuss it as well, contraindicated, in another video. IMF, intermaxillary fixation. Then L for loose teeth, and other L for lack of posterior teeth. Now the surgical approach. To remember the surgical approach names, you must remember one word, that is rise. Okay. Now P stands for the post auricular. R stands for rhidectomy or retromandibular. I stands for the intraoral. S stands for the submandibular. E stands for endoscopic approach research. Now the surgical procedure. I'll just sum up the surgical procedure in a simple flowchart for you to understand. So first of all, what we do is application of arch bar. Then we approximate exposure and reduction of non-condylar fractures. Then we do the IMF and fixation of non-condylar fracture. Then we replace the wires with inter-arch elastics. Then we go to the retromandibular approach. Now here we will do platysma and parotid capsule incision, reduction and fixation of condylar fracture. Then recheck the occlusion, and then we do the suturing. Now suppose this is it and we have this, then we will approximate Now complications. To remember the complications, remember that TAD has a lot of best friends. So TAD BFFs, they are friends for forever. So first by T we have TMJ disorder. By A we have ankylosis. By D we have deviation, or you can write about disturbed mandibular growth. By B we can write about bleeding. F, Frey syndrome, because we are approaching it through the parotid capsule. Then F, fistula. Also you can write about, in this you can write about salivary fistula. By F you can write about facial nerve injury. I think I've covered all. Yeah, so this is it. This is about the condylar fracture management, and after this let's discuss about the fractures of ramus or angle of mandible. We find a page. Now ramus. Now for ramus there is going to be horizontal favorable, horizontal unfavorable, vertical favorable, vertical unfavorable. Alright, now in horizontal favorable what you will see is that this is it. Basically there is no displacement, and the fracture line, it is downward and forward. Over here what you will see is that there is going to be displacement. Also the fracture line is going to be backward. Okay, so displacement, it is upward, medially and anteriorly. Now you can remember this by MAU, makeup artist. So, and the fracture line, it is up forward, sorry, it is backward. it is downward and backward. Now here you can just draw like a diagram of the mandible like this, and then you can show that there is basically no displacement, whereas in unfavorable what you will see is completely displaced fractured segment, and like this is lingually displaced fractured segment. Now in clinical features, just remember a few things. There is going to be step deformity at angle externally. Then you can mention about simple things like trismus, dysphagia, pain. Then yeah, you can write about the lower lip paresthesis, deranged occlusion. You can mention it in almost all of the fractures, mostly in clinical features. Then movement at fracture site. Also there is going to be bleeding, so you can write about hematoma. Now for the management part, you must remember a few things. Now in management, either we do the closed reduction or we do the open. Now for closed, what I want you to remember is CFS, or you can remember FCS. So C stands for the comminuted fracture, F stands for favorable, simple, and for this you can remember U. So first is periodontally compromised tooth, then unfavorable fracture, basal triangle fracture by E. edentulous patient. Alright, then we just have one thing left, which is the symphysis and parasymphysis fracture. I think I'll cover it in this video only. So symphysis. So first of all, some classical signs. What you will see is, you will see soft tissue injury in the chin or lip. Now very important, you must remember, is the Coleman sign. Coleman sign. Now what is this sign? It is basically the presence of sublingual hematoma. Alright. Then it is backward and downward, the fracture line. Now due to this, what will happen is there the tongue can fall back. So airway obstruction. Then as I told you, mention malocclusion, retruded chin. Then mandibular nerve paresthesis. Then function is decreased. Alright, so this is simple. Then we can do the closed reduction and the open. So this completes the symphysis and parasymphysis. I hope you understood. Thanks for watching.